Okay, I'm going to start. We've got 10 o'clock, so and then hopefully people will be joining. We've got, I think, 20 minutes to cover this. And what I thought I would cover two things. First, what to do, what should be done, and then a few reflections on how to do it. Hopefully it will be helpful. So first, to start with and to be able to understand better why we do what we do when we suspect trisomy 21 are the most common health problems that are associated with trisomy 21. So eyes, vision problems in about 60% of children, nearsightedness, farsightedness, squint, cataracts, all that stuff. Very often they need to wear glasses. Ear infections and hearing loss, quite significant percentage, thyroid underactive, then leukemia, so transient abnormal myelopathy at birth. That's why we need to do full blood count in film. 10% of these babies will have, if tested for GATA1 gene, they will have the mutation, which then causes them having proper leukemia later on in life. So it's important that we pick that up and investigate. Pneumonia in 60% children, they will have their first episode of pneumonia in the first 2 years of age. So infections, respiratory infections are quite prominent. Heart defects, about 50%, and the most common AVSD, and obviously gastrointestinal, so the most common duodeноatresia, Hirschsprung, celiac disease, and developmental delay. So milestones will be achieved, but later. And there are other things that are being listed, but I never tell the parents that when I actually break the news to them. So things like spine problems, nerve problems affecting gait and joints, epilepsy and mental health disorders. So now, what tests and reviews do we arrange? If we kind of going towards likely trisomy 21, is genetic sample, PCR and CGH arrays at the same time, full blood count and thyroid function for the reasons I mentioned, and cardiology, either inpatient or outpatient. Use your discretion. If the baby is symptomatic, really loud murmur or other symptoms of cardiac disease, then obviously we will insist on having that done as an inpatient. But if the baby is asymptomatic, it's okay to delay it and do it as an outpatient later. If there is just generic dysmorphic baby, we also send genetic sample, PCR and CGH arrays. We usually ask geneticists for review. We arrange renal ultrasound because we need to know whether there are any renal abnormalities. We arrange ophthalmology review as an inpatient, looking for colobomas and stuff, and cardiology assessment, and either in or outpatient depending on the symptoms. And then follow-up. Once we know that there is trisomy 21 for those, so that kind of the color coding is things that are specific to these conditions, and in the black is that happens with everyone. So all babies get neonatal follow-up in about 2 months, just one off, just to tie up things, chase the results, inform the parents, making sure, check with them how they're gaining weight, feeding, all that stuff. We can involve our outreach team if they are within our catchment area for feeding, weight loss. And then for trisomy 21, we arrange Down syndrome community clinic. All community centers have got specific clinics dedicated to these children. So this is what we request, around 4 months of age, sometimes waiting time is longer. That's why we order that neonatal follow-up as well. They need to remain under ophthalmology surveillance for the reasons we mentioned before. So they don't need to be reviewed as an inpatient, but definitely as an outpatient from about three months of age. Then for the ongoing problems, it used to be special needs health visitors, just as a support for parents, navigate the systems, access to benefit stuff, all that things, and also the mundane growth, feeding, weaning, pooing. This institution has been closed now, and what we are left is so-called 0 to 19 community nurses. This is kind of relatively new structure, and they are sometimes a bit reluctant to take on that follow-up, but because they are programmed, in their mind, they do acute interventions like injections, reviews, cardiac saturation, or things like that. But actually these babies may come with all sorts of problems. So we really want the parents to have that support from the community nurses. When this baby is going home, GP needs to be informed and genetics needs to be sent for counseling. For generic dysmorphic baby, we arrange Mary Sheridan follow-up for high-risk neonatal problems and usually genetics. In terms of timeline, I must say this is probably one of the hardest interactions I ever have. It's hard, dysmorphic baby. It's probably second to when you need to tell the parents that you think they've been harming their baby, like safeguarding issues. I think to me it's still the hardest because one doesn't really know what words to use, at which point do you actually say the Down syndrome or dysmorphic. It's really hard. So I don't think there are any fast rules. I don't think I'm going to give you a ready recipe for what to do, but I'll just try and share things that I've, my thoughts and facts that I've acquired over the years. So generally, there is a bit of escalation towards senior review, and we don't jump immediately with the consultant review. We kind of build it up. So it's okay for the midwife to approach the SHO, but maybe SHO with the registrar should go and do that medical review. Then we give the time for the baby to establish feeding, you know, for the parents to start bonding, for the feeding to present with difficulties if there are to be any. Hopefully we will get the result, especially for trisomy 21. We really want that result before they go home. It's always better. It's very tricky to try and give the parents result over the phone or bring them back. It's like a delayed insult. But sometimes it's not possible and we have to do what we have to do. And then obviously discharge and follow up. So parents, there's variable level of knowledge and awareness, and I divide them into these few groups. So some of them will have some knowledge already. They may have a person with Down syndrome in the family. They know how it looks like. They know what they're dealing with. So they are basically, they look at their baby and they are certain. They all want you to just do something to confirm. Then there are those also very matter-of-factly, they suspect, but they want the certainty. So they want you to do whatever is necessary to either confirm and rule out because they want to move on. And these are that suspect, but they really are in denial. They want you to deny as well. In these groups, I would usually use the kind of very, very precise terms, why we suspect this is Down syndrome. So there you can actually list all those features: flat face, upslanting fissures, large tongue, tone, sandal gap, short fingers. All those things can be listed and then say, and then mention that these are associated with this and this syndrome. But there are those patients, parents, who have no suspicion about any abnormality. So it's just really dropping a bomb on them. And probably the most challenging, those that have no suspicion, but then also have no knowledge about what trisomy 21 is. So explaining genetics to them may be tricky. And in these parents, I would use more roundabout terminology like unusual features. Later on, maybe we will start naming once they know, they have a bit more knowledge. regardless of the parents' level of suspicion or knowledge, we will be breaking their hearts. And I think they need some time to accept that and to arrive at that moment when they believe you that there is something not right. In Holland, I wanted to mention to you, I don't know whether you've met it before, but Emily Kingsley is an American mother who had a son, Jason Kingsley, who's an actor, born with Down syndrome, and she's written that essay back in 1987, and it starts like that. When you're going to have a baby, it's like you're planning a vacation to Italy. You're all excited. You get a whole bunch of guidebooks. You learn a few phrases so you can get around. And then it comes time to pack your bags and head for the airport. And only when you land, the stewardess says, "Welcome to Holland." And then it goes on about how Holland is also a beautiful country and you can get joy and discover and find so many beautiful things there, but it's not the destination where you are heading. This has been helpful to use with some parents to help them cope with the diagnosis. Some people out there in the internet dispute this approach, and they say actually nobody really knows what your baby will be like, so we all end up in Holland in a way, or actually we all end up in Italy, because you take the whole package, the parenthood with all the joys and all the difficulties, and you make what you want as far as you can of it. But just something to use might be useful. What do parents say? There's this paper published based on the interviews with 50 Irish families. A link is there if you would like to go and see the tables. But generally said, the parents have got an array of feelings: shocked, ashamed, confused, angry, anxious. Guilty is the most common. I wanted to bring your attention to the fact that, you know, there's people who don't have much knowledge about genetics. They will always be thinking, have I done something in this pregnancy to cause it? There are some cultures where a woman is always blamed for everything that is not right with the baby. So that's another thing to have in mind when we talk to them. But the message from the parent is generally that they want to be spoken as soon as appropriate and in clear terms. They want, if possible, to have company with them. They want positivity. So they want, and we should help them to enjoy having the baby. They have a baby first and foremost, and then this baby has got Down syndrome or not. But they don't, it's not that they've got Down syndrome baby. That's what they want to focus on. And in fairness, in few weeks' time, in first few weeks of time, this will be the main thing for them, just accepting and adjusting to new life with a bigger family, with a baby who will need to be fed and have nappy changed, and we need to bond with them. They want us to use the baby's name, or if they don't have the name yet, then your son or daughter, rather than these babies, those babies, these patients. And only some want privacy. We should check with them when we talk to them whether they are happy to be speaking in a common bay, whether they want to be transferred to side room. People's wishes vary, so it's important to check with them. So what I envisage as ideal approach when the midwives mentions she suspects baby with trisomy 21, I would think that we should maybe go together, SHO and SPR, and for that first encounter. It sends the message that we take it seriously, we are a team, we're going to look after you as a parent, and it gives the registrar the opportunity to lead and teach. It gives the SHO as a possibility, an opportunity to observe and learn and acquire their own experience, but it may not always be possible. So first, of course, we introduce ourselves, then we congratulate the parents on having a healthy, beautiful baby. There's always something we can focus on, how calm or how active, the hair, the color, anything, just to bring the message home, you've got a baby, and that's the most important thing. And most likely, if it's on postnatal ward, the baby is actually healthy. So that's very important. Then inquire about all baby things: feeding, passing urine, meconium, maternal health, tiredness, sleep, colostrum. Just demonstrate to them, you know what they're going through. They, you know, it's tired. It's really tiring, exhausting. Even without that extra worry. At some point, they may just trigger you telling them why you actually came to see them. But if they haven't by then you just check, do you know why we're coming to see? And then be as specific as you can. Your midwife mentioned that your baby has got single palmar crease or as upslanting eyes, something like that. So we're coming to check, and inform them that your intention is actually to perform the full review. Continuing doing the whole review, antenatal details, check whether members of family, maybe baby resembles members of family. You know, in my all years doing this, I had done things both ways. I had suspicions, and then the result was negative. I told the parent, no, I don't think it's Downs, and then later on it was. I think we will all do that at some point. So I am not as confident when I speak to them. Only sometimes, if it's absolutely obvious, I will tell them, yes, I think your baby has got Down syndrome. But very often, it's just kind of feeling your way through, being human, trying to put yourself in their shoes, go with them, be patient, let them arrive with you to the same suspicions, but I would always keep that gate open, because it happened so many times that we had suspicion, but it was not confirmed. I would keep that gate open, that yes, this baby has got this and that, which is most commonly found in babies with Down syndrome, people with Down syndrome, but only the blood test result will tell us for sure. So you can say that. If depending how the situation, how the conversation goes on, if it's one of those when parents accept and they understand we've got suspicions, we need to do something about it, they're happy, just go on and arrange the bloods, send the PCR. The sooner we send it, the sooner we get the result. We are told that it takes 36 hours, but it's from culturing. So if we are taking sample on Friday afternoon, we won't have it probably before Wednesday, because the sample will arrive at Guy's lab on Monday afternoon. That is when it's going to be cultured, and then we will receive the result on Wednesday. So be careful what you promise. If we send the sample at the beginning of the week, then usually 48 hours later from taking the sample, we will have the result. But the 36 hours messages from culturing, be mindful of that, please. If during your discussion you're not certain about how it's going, or parents are very negative, you're not getting through, it's absolutely fine. Leave them, give them time, and kind of maneuver the discussion towards, I'm sure you would like to speak consultants, very important to you, and then, you know, escalate, and somebody will always speak to them. At some point, consultant will always speak to them. The things that also have to be said at some point, and it's hard to predict when it's going to be. It could be at the very beginning, could be very end, when we actually give them the results. So if you asked at the very beginning why, whether you agree, whether you think the baby is has got trisomy 21, I would say you understand why the midwife has raised those concerns, and then you can be specific. The single palmar crease, the shape of the fingers, the shape of the toes. But so you said, but we're just trying to find the answer, and we will doing review, and the blood results again will be the final answer. Very often when they ask, why do you think the baby has got trisomy 21, they often ask, was it my fault? So you really need to make it specific, and then whether you will go into the explanation of genetics at that point or at any other point doesn't matter, but you have to emphasize it. It's not their fault. It's not something they could have done or shouldn't have done in pregnancy. And then also other things that we try to convey at some point. That help is available. There is an info pack in the outreach office with leaflets, pamphlets, information about how to tell the grandparents, how to tell the siblings, what to do in that initial period. We can encourage them and go and find support groups. There's a lot of them on the internet. We need to inform them that we will be arranging all the follow-up, so they will not be left alone. There will always be someone guiding them through that the early weeks. Then mention that if you think at some point it's appropriate, that yes, it's something they have not expected, but nobody really knows how their baby will be before the baby is actually born and or grown up. But it will be enjoyable, equally beautiful, and an experience full of love, and this new person will enrich the family life as any other baby would. And also that it's okay to cry. It's okay to cry. I sometimes do say sorry to them, although we shouldn't be sorry that they've got a baby. It's just, I think, being sympathetic. You know, even if the feeling is that it will enrich their experience overall in life, you know, soul searching here, but I had fought cancer some time ago, and even if I think that it made me a better person, when I speak to someone who has got the diagnosis, I would still tell them I'm sorry, because it's not something you wish anybody to go through, even if from the hindsight it may have some positive impact on your life. I would still be sympathetic. So in kind of those terms, try to be there for them, be sympathetic, and say sorry, but not for them having the baby, just for them going through that grieving period. It is a grieving period. They grieve for the baby they imagined. And they need to learn how to love that baby that is just in front of them. Why would we avoid delay testing? Sometimes it's okay if baby, especially if they're very subtle features and we're not certain at all whether this baby is dysmorphic. I'm talking in general terms as well as trisomy 21. I had a situation we dealt with Muriel Holder, our geneticist. We've referred very early on a baby that seemed dysmorphic to us. And 6 months later, it turned out to be nothing. The baby grew, the dysmorphic features kind of became less obvious, because that's what happens with time. They either become more obvious or less. And then 6 months later, this mom told Muriel that she wished she had never been told there was anything wrong with that baby, because it really spoiled the whole early neonatal period for her. The bonding, the precious moments, it was just tainted and burdened with a lot of negativity. So this makes me really cautious when I am to go and tell the parents, I think this baby is abnormal looking, has got dysmorphic features, has got genetic. It's so hard. So, and sorry, it's going to get only harder for you. So all we can do is just try our best. And if the parents don't want to hear it at the time, it's still okay. As long as baby's safe, we can always, arrange outreach team to go and have a look at them, because the feeding, weight gain will be an issue. And we can tell them what they should do if they at some point realize the baby's not behaving as they think that baby should, speaking to midwives, to health visitor, to GP. We can give them the safety net, and leave them at that. And that's all I wanted to say. So please, if there is anything you would like to ask.
Thank you, Gosha. It's Charlotte. That was really helpful. I was just wondering if we have a guideline that we use for babies that we're suspecting trisomy 21. I haven't come across a baby like this in the postnatal ward since I've been here, and I just wondered if there was a guideline with kind of a structured thing for the juniors to work through, like tests and referrals and things, and maybe local contacts.
Yes, it's in the postnatal chapter, approach to dysmorphic baby. It's all there, including all the follow-up that I mentioned, and the full blood count and the thyroid function. All that is there.
Perfect, thank you.
Thanks so much, Gosha. That was brilliant. We'll see you soon.
Everyone's thanking you on the chat, Gosha.
And if you want to do any more, that'd be amazing, because it's so helpful to all of us.
Thank you, guys. Thank you very much. Have a good day.